Welcome everyone. Today's topic is ACLS, Advanced Cardiovascular Life Support. It's not just CPR. It's about saving lives through teamwork and quick action. Let's start by understanding what happens when the heart stops. Before we start, let's look at today's goals. We'll learn what happens when the heart stops, how to do high-quality CPR, and how every step in the chain of survival saves a life. We'll also talk about common barriers, ETCO2 monitoring, and how feedback devices help us improve CPR quality. Now let's understand what happens when the heart fails to pump effectively. Cardiovascular collapse means a sudden loss of blood flow. Sometimes it recovers on its own, but sometimes it progresses to cardiac arrest. Cardiac arrest means the heart has stopped beating effectively. No pulse, no response, and no normal breathing. You might still see gasping, but that's not real breathing. It just shows there's still a bit of blood flow left in the body. Now that we know what cardiac arrest means, let's talk about ACLS, Advanced Cardiovascular Life Support. It's a set of advanced guidelines used to treat serious heart emergencies, such as cardiac arrest, stroke, or heart attack. ACLS certification helps healthcare providers respond fast and effectively, using CPR, defibrillation, airway management, and teamwork to save lives. Next, let's look at the three key parts of ACLS. Airway management, keeping the airway open with advanced tools like intubation. Pharmacology, using drugs like epinephrine or amiodarone during resuscitation. Team dynamics, working together smoothly as one team during a code. ACLS combines both theory and hands-on practice, and certification must be renewed every 2 years. Now let's move from theory to practice. When managing a CPR case in the hospital, we always follow a structured algorithm based on basic life support and advanced cardiovascular life every step. From checking the patient, starting compressions, to managing airway and circulation, follows a clear sequence to give the patient the best chance of survival. Here we also see two key terms, preload and afterload, which affect how the heart pumps blood effectively. Now let's move into action. What do we do first? Step 1. Ensure scene safety. Make sure it's safe for you and the patient. Step 2. Check for responsiveness. Tap and shout, "Are you okay?" Step 3. Call for help. Activate the emergency system and get the AED or defibrillator. Step 4. Check breathing and pulse within 10 seconds. If no breathing or only gasping and no pulse, start CPR. If breathing and pulse are normal, monitor until help arrives. Once we've checked for breathing and pulse, the next step is to take immediate action based on what we find. We start with proper patient positioning, then begin CPR if there's no pulse. Use the AED for defibrillation as soon as it's available. If it's a respiratory arrest, provide rescue breathing. If there's choking, relieve the obstruction quickly. And in opioid-related cases, give naloxone as early as possible. Let's start with the first key element, chest compressions. The rate should be 100 to 120 per minute, and the depth at least 2 inches or 5 centimeters. After every compression, allow the chest to fully recoil. This helps the heart refill with blood. And remember, minimize interruptions. Try to keep every pause under 10 seconds. After good chest compressions, the next step is to open the airway. Use the head tilt, chin lift technique to lift the tongue and open the passage. If trauma is suspected, use the jaw thrust instead to avoid neck movement. Make sure the airway is clear before giving any rescue breaths. After compressions and opening the airway, the next step is breathing. Give 2 breaths after every 30 compressions. Each breath should last about 1 second, and you should see the chest rise. If the patient has an advanced airway like an ET tube, give 1 breath every 6 seconds, while compressions continue without pause. Once the AED or defibrillator arrives, act fast. Step 1. Turn it on. Step 2. Apply the pads firmly to the patient's chest. Step 3. Analyze the rhythm. If the rhythm is shockable, for example VFib or pulseless VTach, give 1 shock immediately, then go straight back to CPR for 2 minutes. Don't waste time, every second counts. Before we analyze cardiac rhythms, let's review the basic PQ/ST properties on the ECG. The P wave represents atrial depolarization, the atria contracting. The QRS complex shows ventricular depolarization, the ventricles contracting. The T wave is ventricular repolarization, the heart getting ready for the next beat. We also measure intervals like PR, QRS, and QT, because changes here can tell us if conduction is delayed or abnormal. After CPR and defibrillation, the next step is IV access and medications. Give epinephrine 1 mg IV or IO every 3 to 5 minutes. And if the rhythm is shockable but not responding, use amiodarone. At the same time, always look for reversible causes, the H's and T's. Hypoxia, hypovolemia, acidosis, hydrogen ion, hypo, or hyperkalemia, hypothermia, tension, pneumothorax, cardiac tamponade, toxins, thrombosis, either coronary or pulmonary. Correcting these causes can make the difference between success and failure. When the patient regains a pulse, we call that our OSC, or return of spontaneous circulation. Our job isn't done yet. Now we focus on supporting breathing and circulation and carefully managing the airway. Keep oxygen saturation above 94% and monitor for arrhythmias because the heart may still be unstable. Finally, consider targeted temperature management to protect the brain and improve long-term recovery. Good CPR is never a one-person job. It's all about teamwork. Assign clear roles in the team, one for compressions, one for airway, one for medications, one for monitoring, and a team leader to coordinate. Use a metronome or feedback device if available. It helps keep rhythm and depth consistent. Rotate compressors every 2 minutes to avoid fatigue. And finally, always debrief after the case. Talk about what went well and what can be improved next time. Let's do a quick recap with visuals. These are the CPR steps for adults. Step 1. Check responsiveness and pulse. Step 2. Start chest compressions. Hands at the center of the chest. Push hard and fast at least 5 centimeters deep, 100 to 120 times per minute. Step 3. Open the airway using head tilt, chin lift. Step 4. Give 2 rescue breaths, each lasting 1 second. Watch the chest rise. Continue the 30:2 cycle until AED arrives or help takes over. Before we move on to abnormal rhythms, let's first look at what a normal sinus rhythm looks like on ECG. You can see a clear P wave before each QRS complex, followed by a T wave, all evenly spaced. The rate is between 60 and 100 beats per minute, which means the heart's electrical activity is working normally. Now let's look at 2 common rhythm variations, sinus bradycardia and sinus tachycardia. Both have normal P waves, QRS complexes, and T waves. The only difference is the heart rate. In sinus bradycardia, the heart rate is below 60 BPM. If the patient is symptomatic, for example, dizzy or hypotensive, we treat with atropine or start dopamine or epinephrine infusion. In sinus tachycardia, the rate is above 100 BPM at rest. Usually it's a response to stress, fever, or pain, so we manage by treating the underlying cause rather than giving drugs immediately. Now let's look at AV blocks, where the signal from the atria slows or fails to reach the ventricles. First-degree AV block is not a true block. It's just a delay. The PR interval is longer than 0.20 seconds, but every P wave is still followed by a QRS complex. The rhythm stays regular. Usually, no treatment is needed unless the patient is symptomatic. Second-degree AV block type 1, also called Mobitz I or Wenckebach, shows a gradual lengthening of the PR interval until 1 beat drops. The treatment includes atropine, dopamine, or transcutaneous pacing if the patient is unstable. Next, let's look at the more serious AV blocks. Second-degree AV block type 2, Mobitz II. Here, the PR interval is constant, not getting longer. But suddenly a QRS complex drops, often in a pattern like 3:1 or 4:1. This type can progress quickly to complete heart block, so the treatment is transcutaneous pacing as soon as possible. Third-degree AV block, also called complete heart block, means there is no connection between the P waves and QRS complexes. The atria and ventricles beat independently. It's a medical emergency. Start transcutaneous pacing immediately and prepare for permanent pacemaker placement. These are 2 of the most life-threatening rhythms you'll ever see. On the left, ventricular tachycardia, or VTach, you'll notice wide, abnormal Q are S complexes and no visible P waves. The heart rate is usually above 100 BPM, and it can quickly deteriorate into ventricular fibrillation. Treatment is immediate defibrillation. Don't wait. On the right, pulseless ventricular fibrillation, or VFib, the ECG looks completely chaotic and disorganized. The patient has no pulse, and CPR with defibrillation is essential, along with epinephrine, amiodarone, or lidocaine per ACLS protocol. Let's imagine the heart as a donkey pulling a heavy cart. The cart represents the body's workload, or the blood it needs to pump. When the load becomes too heavy, the donkey gets tired, just like the failing heart that can no longer keep up. So how do we help the donkey? We can reduce the preload, lighten the cart. We can decrease the afterload, make the road smoother. And we can improve contractility, give the donkey more strength. That's exactly how we treat heart failure, by reducing the burden and helping the heart work more efficiently. That brings us to the end of today's session. We've covered the key points of ACLS, from CPR basics to advanced rhythm management. Remember, early recognition, high-quality CPR, and teamwork save lives. Now I'd love to hear from you. Do you have any questions or anything you'd like to review again?